Welcome to Heroic Herstories, Women in Medicine with the Katies. This podcast is to document stories of women trailblazers in medicine in the state of Iowa. We will highlight seasoned women in medicine to create a brief oral history of their works and lives. We want to learn from their experiences, share their vast knowledge, and gain insight into the challenges they have faced. Our goal is to lift up those who have gone ahead of us and thank them for their incredible service and dedication to our wonderful field. Hey, Katie.
Hi, Katie. So today we're welcoming Dr. Kyle Brown. Dr. Brown, how would you like us to address you during our chat today?
Oh, you can call me Kyle. That's fine.
Kyle it is.
Yeah.
So Kyle graduated from Case Western Reserve with her bachelor's degree and then won the American Friends of the London School of Economics Scholarship for Postgraduate Study Award, which took her across the pond to earn her Master's of Economics. She returned to the U.S. and went to medical school at Case Western Reserve, graduating in 1986 and staying on for her residency in internal medicine. She worked for 1 year at Case Western, then moved to the University of Virginia for her gastroenterology fellowship. Following her fellowship, she moved to St. Louis, Missouri, and worked at St. Louis University, the VA, and St. Mary's Hospital. She then came to Iowa City to join the faculty at the University of Iowa in 2001. She's been an active member in the fellowship for gastroenterology, the director of the endoscopy service at the VA, and the program in free radical and radiation biology. She's won multiple research awards throughout her career and recently won the Outstanding Mentor for Medical Student Researchers Award in 2023. She's a well-known teacher of medical students, residents, fellows, and faculty. We in general medicine and primary care, like Katie and I, have benefited immensely from her talks to help us in seeing our patients with liver disease. She's published a ton, especially in the areas of cirrhosis and iron overload. She continues to publish, see patients, and teach here at the University of Iowa, and we're so happy to have her join us today. Welcome, Dr. Kyle Brown.
Hey, thanks, Dr. Brown. Kyle, sorry.
Thanks for being seasoned. I like it.
Well, we like to start off with the hard-hitting journalistic questions. So just prepare yourself.
I'm taking a deep breath.
Yeah, take a deep breath, get prepared. We noticed, looking at your CV, that you seem to enjoy the weather of the Midwest, being in Iowa and Ohio, and maybe a little more southern weather like Missouri, Virginia, and also a very particular climate, England. So we wanted to ask, if your personality could be described in weather terms, what is the forecast?
Fair with a chance of storms.
Ooh, I love
It's a common one. We have a lot of stormy women in this.
That's right. We need more stormy women out there, right?
You can't get away from it.
Love it.
Okay. Well, we're going to watch out for the storms during this conversation. So if we see any coming, we'll duck and cover.
Yeah.
Kyle, I'm sure that you don't remember this, but 25 years ago, I was a student research assistant for Dr. Lebrecq in the hepatology division when he was looking at complementary and alternative medicine use in his liver patients, his hepatitis C patients. And I remember at that time noticing that you were really the only woman faculty member in that division that I ever saw, as kind of rumbling around those offices in the clinics. And that stuck out to me, even though I was a college kid with no idea how anything worked, but I took note of that. And you were actually the initial inspiration for this podcast, because I was telling Katie about that one day when we were listening to you talk on a panel to medical students about careers in internal medicine. And we talked about how it would be great to get an oral history of what it was like early in your career coming up as young faculty in such a male-dominated division. And so we're really thrilled that you agreed to talk with us today because, again, you were the inspiration. So that's why we're here.
Oh, geez. That's cool. I did not know that. I got to say, I do remember Doug working on the CAM stuff.
Mm-hmm.
I honestly don't remember you specifically.
You wouldn't have any reason. But it was fascinating to me at the time because I'd never done anything like that. I was in college and just wanted to go to med school.
Yeah.
And so it was a great opportunity in hindsight to talk to patients. He sent me in, I had a questionnaire. I was supposed to go in and talk to people about how they got their hep C and what sort of things they were using to treat it that they wouldn't otherwise tell the doctor about. That's how I learned that intranasal cocaine is a great way to get hepatitis C.
Oh yeah.
I didn't know that before.
Yeah.
I made it almost all the way through college without knowing that. So that was risky.
Yeah. That's still something a lot of people don't know, but it's in the literature,
I'm spreading the word. I tell all the students who work with me about that because it blew my mind.
Yeah.
Well, and Kyle, I must say that Katie and I discussed like asking you about this podcast, and I like ran up to you after the meeting, and I was like, Dr. Brown, would you be willing to do this? And you're like, hell yeah. And I was like, okay, let's do it. So we were so excited.
Why not? Right?
Yeah. So one of our just, basic questions is just, what drew you to medicine? What made you take that route?
Yeah, it's a pretty random story. I mean,
Love it.
there was certainly no physicians in my family. I had a couple great aunts who were nurses, and but that part of their life was not. I mean, I knew they were nurses, but they were just my cousin's mother, right, sort of thing. But it's, and I don't think I knew what I wanted to do when I was in high school, and but we did have to take one science course. It was a requirement, so I decided to take biology because physics sounded boring, and I really like biology, and I kind of almost remember having a distinct thought in my head, like, this is really nice, but like, how you couldn't make a living doing this.
Yes.
Because that's how like clueless I was about medicine, right?
Yeah. Yeah.
So anyhow, the rest of the story is even more random. So I think it must have been between like junior and senior year in high school. I picked up this book, and this is really important. The name of the book is The Making of a Surgeon. Have you either one of you guys ever read that book? Okay.
Oh.
So it was written by this guy named William Nolan, and he probably trained in the 50s, I think, at Bellevue in New York. And the book was maybe written in the early 60s, so it was even old when I read it. But it's great stuff. I mean, it's like general surgery, blood and guts. I mean, you can't not read it and get excited, right? And then I was like, oh, holy shit, this is the practical application of biology. I was like, oh, so this is what you do with this thing, right? Yeah. So that was really what did it. And the funny thing is, I mean, this may be a false memory. I have to go back and read this book again because I read it in high school, right? But my only actual recollection of any specific thing in the book is he talks about doing portacaval shunts on variceal bleeders. Now, why would I remember that? I mean, because portacable shunts have been done for a long time, but the fact that I kind of like that's something from that book that I remember like 40 years later, it's like that's pretty weird. Maybe he did. Maybe I'm making it up, but I'll reread the book sometime and see.
Well, that was probably in your subconscious when you chose to do GI. Like it was.
Yeah. Yeah. But anyhow, it's a very gripping book, and it's a great read. Although of course very dated at this point. But you just can't read it and not get excited about medicine.
I love that you point out that like. I remember thinking like with biology, so you become a biologist, like, like I'm just supposed to add ist to what this is. And that is kind of like, how would people know when they're in high school that,
Although I have to say, I mean, it couldn't have been as like blind. I couldn't have been as blind as that because I remember we had like our biology teacher was really cool. She was a young woman, recent college graduate. And one of the assignments that she gave us, like we were learning about different body systems and stuff, was she actually sent us to the Merck manual to like write a report on something. And I remember I did a report on SBE. So I mean, like again, like I remember what I did that little book report on. And so I guess it should have been clear to me at that point what the practical application biology was. It took a little longer for the message to sink in, I guess. I don't know. Or for me to actually kind of say, yeah, a person could actually do this, Yeah.
It's always clear in retrospect, right? Yeah. Love it.
Well, and speaking of your path to medical training, so, a lot of people backpack around Europe or do some sort of scribing during their gap year, but you got this master's from the London School of Economics, which I Googled it. And it's educated 25% of all the Nobel Prize in economics recipients, but you're the only heroic Herstories guest to date to be educated there. So,
and probably for a long time to come, I expect. Yeah,
potentially. We can't be sure. Once this goes viral, we will probably have a lot of applicants. But
a lot of people come out of the woodwork,
Yeah.
So,
so tell us about that journey. Tell us about why you went there and what you studied.
So by the time I went to college, I knew I wanted to be that medical school was my pathway, and so for some, again, kind of random reason, when I was a freshman, I picked up this course in biological anthropology, which I really liked. I mean, it was like population genetics and osteology. Like at Case, there's this huge osteologic collection that dates back to the early 20th century, like people who were too poor to get buried. Their skeletons were collected, and like you can look at signs of TB and syphilis and all kinds of interesting things. Anyhow, so that was super interesting. And I thought to myself, and Case, I'm sure it's different now, but maybe it's not. I mean, my daughter went to Case, she would have some insight into this. It was a very, I mean, excellent education, but like people were very serious. It was like the polar opposite of a party school. And there were a lot of people who were pre-professional, pre-med, pre-dental, pre-law. Anyhow, so this actually was like a great discovery for me, because it's like, hey, I can study this thing and it's like relevant to my career goals. And there aren't a lot of pre-meds in this, because, I didn't want to have to like hang out with all the biology majors. Not that they weren't fine people. It's just like, it was like a very competitive environment. Let's put it that way. And anthropology, it was like this unknown thing where you could kind of study this stuff that was very interesting and relevant, but not highly trafficked by the pre-med communities. So anyhow, got into anthropology, and so that was my major. And I did a junior year abroad in the UK as well. I went to the University of Sussex. And it was super weird because, again, it turns out that anthropology is a different thing on different sides of the Atlantic, and which I had not realized before I signed up to do this thing. But it was interesting, and I learned it was more like sociology. Anyhow, I loved it. I loved it. I mean, I've always been kind of an Anglophile, but like, I just loved it. And so I was looking for an excuse to go back.
Oh.
And so I did my senior year in college, MCATs, all that stuff. And I actually got accepted, and I wanted to go to Case because that was my first choice school. But I also knew that Case, like historically, is like, they liked people with weird stories, weird career paths. And so I was pretty sure that if I got into LSE, that Case would defer me for a year, and they did. And so I then went to LSE, and it was, it was nothing other than like spending time doing stuff that was fun and interesting and not very relevant. But I'll tell you, I got so into it. By the time I came back, I was kind of like, I was kind of torn about coming back and going to medical school, because I would have had the option to stay there and like do a PhD and blah 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 blah.
Wow.
But then I came back, and my mentor from my undergraduate, he was like, "You can always do that later. Go to medical school." So he was like, he was being practical, So I did.
Wow. So then following medical school, you obviously went the kind of internal medicine route. And then I'm just curious, what drew you to GI? Was it, I mean, it sounds like research was an interest of yours. Was it research or more clinical based?
Well, I really wasn't that. I should have been. If I'd been more interested in research, then I would probably had a different career trajectory. I didn't get interested in that until later. But so couple things. So I trained at the hospital that was known at the time as Cleveland Metropolitan General Hospital, so it was a county hospital. So we had a lot of liver patients, but we also, I mean, it was the GI faculty there was probably like less than half the size of our faculty here. So everybody did everything. It's not, they were way less specialized than we are, but they were very charismatic. In fact, even though it's a county hospital, up until at least, I don't know, recently, so the main professional organization for hepatologists is the American Association for the Study of Liver Disease, and which only started like in 1950. And as of like a couple years ago, there had been as many presidents of, and they're elected by the membership, right? There had been as many presidents of the AASLD who came from that little county hospital as from like Mount Sinai in New York.
Wow.
So there's always been like this really well-developed liver research group there, and like very, really strong people and, charismatic people. And so it turned out like there were a bunch of us that went into GI because, it's so influenced by the people that you are exposed to as a student and a trainee, right? And you see these people and you go, I want to be like that person.
Yeah.
And so this is how, we ended up kind of that. And I mean, I liked medicine, but I mean, my choices were basically general medicine or GI. Nothing else really appealed. And I kind of liked procedures.
Yeah.
And I will tell you, I tell everybody this story because it's true. When I was about a second year resident, I went to one of the GI guys and I asked him, when was the last time you looked at an EKG? And he said, I don't remember. And I said, I want that job. That's the job.
Sign me up.
So that clearly, that only left one option, and that was GI. So.
Okay. Love it.
In 2017, the AAMC published data that 82% of practicing GI doctors are male. So that's within the past 10 years. And so we're guessing in 1993, the number of women in GI was even lower. What impact did sort of the gender distribution have on your choice to pursue GI and in that?
I used to say, I have, over the years, I mostly go to the liver meeting. But earlier in my career, I went to DDW, which is the huge, enormous GI meeting. And I used to joke, like early in my career, that the nice thing about going to DDW was there's never any lines in the women's bathroom. But I think that has changed. I don't know how much it's changed. But so here's the thing. So my little county hospital where I trained, small program, there was one of the faculty was a woman. There was, when I was a resident, one of the fellows was a woman. There was a woman, a resident a year ahead of me who went, so that there were actually, for most of the time that I was a resident, there were 2 women of the, I can't remember, like maybe 6 total GI fellows. So it didn't seem weird to me, right? I mean, I had no perception of the fact that the women were underrepresented in GI. And then when I did my fellowship, though, that became clear because when I showed up at UVA, they had gone from having 2 fellows a year to 3 fellows a year, my year, and the year I started, and 2 of us were women, and people actually like talked about it. It was a thing. My God, 2 women in GI. And that made me nervous.
Yeah.
Oh dear, so what are the expectations here? Anyhow, so, but, it was what it was. I mean, I didn't, I'd gotten to that point, I was already into it, right? So I wasn't backing out. I mean, there were times when I wanted to back out, but that wasn't the reason.
Right. Did you have any trouble finding mentorship, or was that straightforward?
Well, I did, but I mean, it had nothing to do with the gender issue, I would say. It was more, I ultimately decided that I was interested in doing some bench research, and there really wasn't anybody in our division who was doing bench research. And so I ended up having to go outside of my division. And so I ended up pursuing a path that was a little bit like outside the norm in that sense, but it all worked out. But I don't know that would have been any different if I had been male in that respect, too.
What kind of prompted that? I don't want to say segue, but I guess, move towards bench research? Was that during fellowship? And
yeah, that was during fellowship. I mean, I had gotten involved sort of, I wouldn't say deeply, in a animal study on actually porticable shunts.
It comes back.
Yeah, actually it did, because I mean, so this one person I had worked with at Metro as a resident doing some fellowship research in preparation for fellowship was using that model, because it turns out that male rats and female rats have very different responses to that. And that was what he was interested in. And so my job was to like weigh the rats every day, which was not very exciting. But learning to not get bitten by rats when you're messing with them was an important first step. No, I don't actually remember why I suddenly thought that I wanted to do that. I mean, that's a good question, Jack. I mean, I thought it was sort of expected. And in those days, a lot of GI fellowships were only 2 years. But a lot, in contrast, university-based fellowships were 3, because there was an expectation that you would spend at least a year doing research and bench research. That was kind of a crazy thing, and it's kind of gone away. But and I don't think anybody, I mean, there were people that I trained with who never did that, and they got along just fine. But I actually wanted to do the thing. And then once I kind of got into it, And, that was something I had an interest in. But exactly why I thought I wanted to do that, hard to say right now. That was a while ago.
Yeah, understood. And then what made you move then? It looked like St. Louis and Iowa. What were the big reasons for the moves?
So I hated my fellowship. No, I will say I was very unhappy at UVA. And part of that might have been because I'd taken that year off between residency and fellowship. And I've been I've been an attending.
Mhm.
Maybe I was just, I think I maybe had a little bit of a adjustment to that. I think that's me being like very fair to UVA. And I think UVA is a great place. There are a lot of good people there now, but they treated fellows like we were idiots. And I didn't have a good, that's why I said when I thought about quitting, that I don't think that was specific to me. I think, and I'm sort of like, I wear my heart on my sleeve, right? And so if I'm not happy, I'm not happy. I mean, I'm not a smile and make nice person. It just, I can't, I just don't. So, and that didn't help because I think that some of my co-fellows were better at doing that kind of stuff. Anyhow, so although I had initially thought, well, maybe I'll stay because Charlottesville was a beautiful place, right? I thought this is great,
Yeah.
But then I wasn't there very long, and I thought I don't like this place.
Yeah.
Sorry, Charlottesville. Sorry, all the fine people that trained me there. And like I say, I think it is a nicer place now, but it was not at the time. Anyhow, so I needed to go someplace where I wanted to do liver mostly, and I wanted to be able to do research. And there was the guy who I'd gone to and asked about the EKGs when I was a resident was at that point the division chief in St. Louis at St. Louis U.
That's amazing.
So I circled back, got in touch with him, said, "Hey, I'm going to be looking for a job, blah, blah, blah." He's a great, I mean, he's elderly now, and I gather not in such good health, but he's a wonderful man. And he made it happen for me. So that's how I ended up in St. Louis. So then I was there for about 8 years, mostly at the VA. I am a long-term VA employee. Actually, the guy whose lab I ended up in when I needed to get into a lab at UVA and couldn't find a lab, he had done his PhD here. And then he ended up back here in radiation oncology. And so when he ended up back here, he was like, "Hey, you should come to Iowa." And I said, "Okay."
And so is that the connection with the radiation enteritis part of your research then?
Well, I mean, I don't really have a research program in radiation enteritis. I've had what do I call it, a secondary appointment in the radiation biology program, which I wouldn't say I've been real active in recent years, although I have ended up being on like some PhD committees because there are people who like are doing things where they kind of want somebody with some clinical knowledge on the committee and stuff. But that was the connection and the reason I ended up here.
Is there any, as you think back, because you've taken care of liver patients through, some revolutionary changes in liver disease, especially hepatitis C, because I am old enough to remember when we really couldn't treat that very well and people were on interferon and ribavirin and felt almost worse than they did with cirrhosis. Can you tell us a little bit about some patient stories or some things that really jump out at you from when you reflect on your career taking care of liver patients?
Well, I mean, you're absolutely correct. I mean, when hepatitis C was discovered in 1989 when I was a third-year resident. And they were using interferon even before they had identified the virus. And that continued up until 2014. And so all these people that we tortured with interferon, and then now not at all, I haven't used interferon in 10 years, right? So there are people there are people I think about who we probably could have saved if we'd had these therapies, more than if we'd had them earlier. There are people who have had miraculous turnarounds. Alcohol is the worst problem. Well, it's not the worst problem. Fatty liver is probably the worst problem, but alcohol is a bad problem. And like the patients, having been here now for 24 years this summer, I think. Wow. It's kind of funny sometimes. I'll be seeing patients in clinic with a resident or so. I've known this patient for a long time, and I look back and I see when the first visit was, and I go, "Holy cow!" I have known this person for a really long time. And some of those people are patients with alcoholic liver disease. I have one patient who shall remain nameless, although he would probably be delighted if I put his name out, but I'm not going to. Because he knows, because I told him that when I talk to the med students about alcoholic hepatitis, I show his lab data because he is the sickest guy that I've ever known to recover. He had a peak bilirubin of 45 and a peak creatinine of 6, and by rights should not be alive today, but he still is. And he turned around, and I saw him about a month ago in the clinic. And he said to me, "Are you still telling the students about me?" And I, yes.
Does he still have the liver he was born with, or?
He does.
Wow.
So yeah, I mean, those are the, like, you know, to me, that's actually probably one of the most interesting things about taking care of patients with liver problems is how I mean, sure, there's a lot of people that get to a point where we can't help them, but there are people where, like, the turnaround is miraculous, even short of transplant. And I'm only peripherally, involved with the transplant thing. I'm not trained as a transplant hepatologist. Of course, those people also can have miraculous turnarounds, but I always tell patients, original parts are best. So if we can get you better in a way that doesn't require transplant, that is by far the best possible outcome. So
I think that's so good to hear, because primarily I'm in the hospital and I see these patients where I'm just like, there's no way they're going to recover, and then just to hear that some of the sickest ones you're following, years and years later, I'm just like, that's a good thing for me to remember.
it is. To be fair, is that a typical story? It is not.
Right.
But I actually I feel conflicted, because when we have students or residents with us on the inpatient service, I feel bad about the experience that they have, because it's not uplifting, shall we say.
Yeah.
On the other hand, if they see patients with me in clinic, they may find it rather boring, because like, these are all but I remember as a student, I did an oncology rotation, and talking to the attending, and he's like, you guys, when you see the patients on the inpatient service, everybody's doing terribly because they're in the hospital, right? But if you want to see the patients that are doing well, you come to clinic, right? And it's the same exact thing with hepatology. The people that are doing well are kind of boring for the most part,
Yeah.
When I was a resident, I didn't think anybody survived kidney transplants or liver disease, because you see all of the sickest, most complicated people. And that's why I really like working in the clinic primarily, is because, just like you're saying, like, yes, it's a little bit boring, but then you get a chance to actually get to know the people a little when they're not in extremis and crisis. And it's way more fun, I think.
Right. But for me, the way we have usually worked our clinic inpatient interaction is that the hepatologist who sees the patient on the consult service becomes their hepatologist. So then that patient comes back to you in clinic. So that's nice, because these people are super complicated, and it's way less painful to review the chart when you were actually, what happened because you were on service, right? And then to pick up somebody cold, oh God, that's painful. But then I also see these people, like this guy I was telling you about. I mean, he was, for months, I couldn't have him on any diuretics. He was coming in every 2 weeks for taps. And then, like, 6 months into this, like, he's like, I don't think I need a tap in 2 weeks. And then his creatinine was improving, and his billy had already improved. So, and ever since then, when I see him, it's all the stuff we talk about has nothing to do with his liver.
Yeah.
Because his bilirubin is 0.8.
Yeah.
Livers are great organs,
Yeah.
And so now he's just dealing with all the sequela of, aging and, DJG and all this kind of stuff, right?
Yeah. So now, after 24 years here, we found out why you came to Iowa originally. What makes you stay? What do you, why are you still here?
Inertia.
What was inertia? Yes.
Yeah. No, it's good. I mean, it's fine. I've had the opportunity. I mean, at some point I was like recruited to be a division director. It's like, you must be kidding. I mean, there is no job on earth I would be. I mean, kudos to Dave Elliott. He does a great job. And the reason Dave is a great division director is because we made him do the job. I don't think he wanted the job, but to be an administrator is, like, so far from anything I'd want to do. So I've been comfortable here because I can do what I want to do. And I kind of, I see almost exclusively, in my clinics, I see exclusively liver patients. I exclusively attend on the liver service here. At the VA, I do some general GI, but as little as can be managed. Because anymore, I'm a competent endoscopist, but, like, I haven't a clue about how to manage inflammatory bowel disease. And I'm, it's become it's much more complicated than when I trained, lots more drugs. And we've got people here who are really great at that, and they spend all their time doing it. By the same token, I don't want those people messing with my liver patients, But
Hands off.
yeah, no, we because we are pretty super specialized here, but we are a tertiary care center, and I think that's okay,
Yeah.
So,
okay,
I'm content. I think that's why I'm
Love it.
content.
Do you think, is there any good advice you've ever gotten?
Yes. The year before I went off to fellowship, when I was moonlighting,
Mhm.
I was working at this place, and I was working with this guy who was a family medicine doc, and this lady came in. This is a terrible story. She came in with belly pain, and I examined her, as one is wont to do, right? And I realized that she was in labor.
Oh no.
Oh my gosh. Oh my gosh.
And she wasn't really quite sure when her last period had been, but my best guess was that this was going to be quite a premature baby, and I scared the living daylights out of me, and so I pretty much ran out of the room because we were at an urgent care. There was a hospital like a mile up the road, but I needed to call an ambulance to take her to the hospital. He said to me, "Take your own pulse first." I thought that was good advice. Just I'm generally not a panicky kind of person, but that's because I was like, I had no idea what I would do with a preemie infant resuscitation. I had zero experience with that, and I didn't want to have any experience with it, honestly. I wanted to let the professionals handle it.
Yeah. Well, that's why we're internal medicine. We don't deal with that.
Right. That's
If we can help it. Check your own pulse first. Okay, that's a good one.
I love it. And I guess I wanted to give you the chance in case you had any other stories or any other memories in particular that you wanted to share with us about your career or life or anything you want to share, open-ended.
Oh my goodness. I'm a veritable font of anecdotes. So that's kind of, we're going into dangerous territory.
We
and the
love.
question
This is what we want.
Where do you start, man? Where do you start?
Well, I guess one thing, medical school. I guess when I went to medical school, it was about 50-50% women, men.
Mhm.
And we've heard actually from different women, very different, percentages in different parts of the country. So what was yours like?
No, I think we were 50-50 at least.
Okay.
Case, has been always kind of a progressive place, I would say. I don't know if it still is, but there was no problem with representation at the medical school level.
That's wonderful.
So that had been the case for a while, so it wasn't like a new thing.
Kyle, we have some rapid fires.
Okay.
All right. If you could go back and meet yourself on the first day of internship, what would you tell yourself?
It's going to be okay. I was scared. I was scared. Yeah.
It was so scary. Yeah.
Yeah.
Okay.
I feel like we need to really look at the medical training system because everybody's answer is like, it's going to be okay.
Yeah.
It's going to be okay. Like we're all terrified.
Yeah.
But I think I would argue that because I think it's actually
it's true.
You're taking on a lot of responsibility, and you know a lot, but you don't know as much as you need to know. So to not be scared would be to suggest you're a sort of a sociopath and you don't care.
Right.
It's true.
So to be a gastroenterologist, you have to have a high threshold for handling gross stuff. Is there anything in medicine that grosses you out?
Absolutely.
What is
Sputum.
it? Sputum. It's Katie's too.
You guys are youngsters, but before CLIA, as medical students, we used to have to collect specimens, and we would actually do gram stains on urine, sputum. Sputum was by far the most disgusting thing. Especially if it's really not just like spit, like sputum, like, ooh, that stuff is rubbery. Ooh.
No.
Yeah. Do trachs make you nervous?
Nothing compared to sputum.
Kyle, do trachs make you nervous or no?
Don't like them, but fortunately I don't deal with them very often.
Good point. Yeah, good point.
Yeah.
Okay. We love to ask women doctors, any thoughts on menopause that you'd like to share with us?
I would encourage it. I think it's a good thing. There's a season for everything, right? And there's some advantages, believe me.
Okay.
Any embarrassing situation that you can share with us? Katie dropped her pager in a toilet.
Oh, everybody's dropped their pager in a toilet.
Right. See, I have many.
This is a great story, a great / terrible story. My very first liver biopsy. So, so the very first liver biopsy I was meant to do. So I'm being taught by a fellow because this is the the age old tradition of being taught by
See one,
somebody
do
who's
one, teach one.
in training, right? So the very first biopsy that came up, and we were doing this is like the beginning. This is 1990, so this is when we probably starting to do more liver biopsies than at any time in the history of the world before or since because of hepatitis C. Anyhow, so this is just the buildup. The the second year fellow says to me, "Do you want to do this biopsy or do you just want to watch it?" And I'd seen like one liver biopsy before this, and I said, "I better let me watch this one." And I was greatly relieved that I'd said that because for some unknown reason they let the patient's wife in the room with him and she said to the second year fellow, "How many of these have you done?" And he was able to give her some number, whereas if it had been me, I would have been like, none. No, but the next one I did do, and this patient had a reaction that, I mean, having done many biopsies since then, was really kind of off the charts. So, you make the pass with the Jamshidi needle, and this patient just leapt up off the bed, scared the hell out of me, and we were all kind of like, there was a few minutes of being like, what's going on? We're very upset. Patient's upset. Let's calm the patient down. Let's see what's going on. And then, so what you do is the core of the liver biopsy should be in your Jamshidi needle, and then you just shoot it into the formalin and send it off to pathology. So after everything kind of calmed down, I, expelled the contents of the needle into the formalin, and there was nothing there. And then it was like, oh my God, we didn't get tissue, and we've got to do this again. And I'm not sure that the patient would have allowed us to do this. This patient just had a terribly exaggerated response to this, let me say. So anyhow, we calmed him down, said, we got to do this, blah, blah, blah. Are you okay? All right, fine, blah, blah, blah. So I'm getting set up to take another pass with this ginormous needle. And the patient's cart is up against the wall. And I looked at the wall.
Oh, no.
And I see this little splotch of red.
Oh, no.
And wait a second.
There's the liver. That's right there.
I got a needle, and it was like, yeah, never mind. Here is our. The liver biopsy ended up on the wall. And I did not live that down. I mean, we talked for a very long time. But I actually was delighted because I didn't have to poke the patient again. So that was.
So you just put it in the formalin and sent it down. Just
yeah. Oh, sure. I mean, just a little.
Pain.
That won't hurt it at all. I think in the hullabaloo of the patient jumping up, I must have just shot it out of the needle.
That's hilarious.
That was true. But it turned out very well. I thought I was happy with the outcome. So,
Thank gosh, I love it. Favorite cafeteria item, food or drink, if you have any.
I probably French fries. I think.
Ooh, good choice.
Although I don't, I really usually get fresh pineapple because fruit is better for you than French fries. So that if I'm going to get something, I'll get pineapple.
Okay.
If the French fries are hot, I will make an exception.
If they're hot, they're hard to resist. That's true.
Mm-hmm. Makes a difference.
I'm just curious with your patients and students. Do you go by Dr. Brown, Kyle, Dr. Kyle? What do you do?
I go by Dr. Brown.
Okay.
I'm old school. I even address my patients as Mr. and Miss because that's just how I was trained. It's getting a little harder now since I am older than most of my patients. So like people that I see who are in their 20s and 30s, I've kind of started referring to them by their first names. But anybody much, unless the patient tells me that they want me to use their first name, in which case I do, right?
Yeah.
But I'm old school. Yeah.
Well, I'm the same. And I'm always surprised because a lot of residents will go in and be like, well, hey, Joe. And I'm like, he's 95. Let's do some respect.
I find that really weird, like coming from the medical students when they're talking to somebody who's like much their senior. It's like, I don't ask them, but it's like, I wonder, like, did they tell you they wanted to be Joe?
Yeah, same.
Is any parting shots, Kyle, anything that you want our learners and listeners to know about your career?
It's been great, honestly. I mean, it's I guess I would say this is very interesting. When I was in med school, they and I think it's still true. There's always been this big push to do primary care. Primary care is great. It's hard, I think. I think primary care is hard. You got to know a lot of stuff. I don't have to know a lot of stuff. I need to know a very small amount of stuff in great detail, right? But it's interesting because the big kind of the push that we got was like, oh, you establish relationships with the person and there's family. And it's like, you know what? I do that too. And honestly, a lot of my patients see me more often than they see their PCP because, if you've got cirrhosis, I'm going to see you every 6 months. And some patients only get seen by their PCP once a year. And so I guess what I would say is, it's kind of what you make of it in terms of if you want those kind of relationships where you know the person, you know their family, you know their dogs, the whole story. It's determined by the type of relationship you develop with the patient and not so much what type of medicine it is you're practicing, I would say. Yeah. I don't know. I think that's probably true.
Love that. And Kyle, we do a historical woman that we like to highlight. We don't know if you're short on time, though. It's okay if you cut out. If you want to hear this part, you're welcome to stay.
Sure.
Okay.
Yeah.
All right. Katie White gets to do this one.
Yeah. So the historical woman that we are highlighting today is Dr. Sarah Jordan, who was the first president of the American Gastroenterological Association. She served in 1942 and 1943. This is the second historical woman we've covered who purportedly got a leadership opportunity due to the absence of male physicians during World War II. So some of these ladies really took advantage of the opportunities when they saw them. So she was born in 1884 in Massachusetts. She graduated from Radcliffe College in 3 years with a degree in the classics. Her parents said, no, you can't go to med school. So she got a PhD. She went to Munich, University of Munich. So she got a PhD in archaeology, graduated with honors. She married a classmate, had a daughter. And then during World War I, her parents talked her into moving home. And so she brought the daughter, moved to the States, and she never actually went back to Europe. So now she's divorced, living on the East Coast as a single mom in 1916. She got accepted to Tufts Medical School on a probationary status in 1917. They said, you can come here, but you need to take chemistry and zoology on top of your medical school classes, because I assume those are prerequisites she didn't get in college, maybe. So she did all that, was not immediately released to graduate, however. So she called up the American Medical Association and said, you need to investigate this. They told Tufts that you be investigated, you have to graduate her, and she graduated top of her class in 1921. She did an internship at the Worcester Memorial Hospital and did a GI fellowship at Rush in Chicago. Her mentor in Chicago was a Dr. Sippy, whose Sippy powders, which was a proprietary mix of sodium bicarb and calcium carbonate, which was like the main treatment for ulcers at that time. So that was her mentor there. And so she really got interested in non-surgical ulcer treatment because that was really all there was at the time. Also, those powders, the Sippy powders, were the subject of a 1954 journal case report about milk alkali syndrome stemming from excessive intake of Sippy powders. She moved back to Massachusetts to raise her daughter, joined her medical school mentor, Dr. Leahy, in a multi-specialty gastroenterology clinic. He was a surgeon and there was an anesthesiologist involved. And so it was kind of an interesting early form of a multi-specialty group. And she got involved in medical treatment of peptic ulcer disease and stomach cancer. She was also sort of ahead of her time in terms of wellness influencing. She wrote a book called Good Food for a Bad Stomach, and she had a daily syndicated column called Health and Happiness, the Counsel of a Wise Doctor. We don't know if she had a podcast. We haven't looked into that yet. So her emphasis was on promoting balance. So she would push things like taking a short nap after lunch and a relaxing highball after dinner. She smoked until she was 51 years old. She played an early morning round of golf every day. And she kind of also was sort of an early proponent of getting outside, fresh air, exercise, sort of balancing your habits and writing about that in the popular lay press, which is sort of interesting. She was on the editorial board of the first GI journal, which was the Journal of Digestive Diseases and Nutrition, which was the official journal of the AGA. But there was some editorial misconduct, unclear. And that journal ended up getting thrown out, and they started the journal Gastroenterology, which we recognize today. And it was kind of the same format, same idea. And that year, she became the first woman president of the AGA, which had 230 members at the time. She went on to a bunch of leadership positions and honors for her work in gastroenterology. She diagnosed her own colon cancer and died in 1959 at the age of 75. So I think she's very interesting for those things. You know, she was sort of in the popular lay press in a way that a lot of physicians weren't at the time. She really was obviously a very motivated and sort of bootstrapped sort of gal, because she made her own way even when her parents weren't interested in supporting her medical career. Being a single mom in that time could not have been straightforward. To be able to do as much as she did in her career, I think that's super fascinating.
That was some amazing investigative journalism there, Katie. I'm impressed.
Yeah, I didn't know about this woman. That's very interesting. When was she president of the AGA? 42? Is that what you said?
42 and 43.
Yeah, that's impressive. Wonderful. Well, Dr. Kyle Brown, thank you so much for joining us today.
Sure. My pleasure. It was fun.
Oh, we loved it. Our many, many listeners, I'm sure, will be listening on all different podcast places and YouTube, and we'll let you know when we get this published. So thank you so much, Kyle. It was so great to talk to you.
My pleasure.